Hey everyone, this is Victor from Cyborg for Life, and I want to welcome you to episode 144 of Limb Lengthening Live, where the patients interview the guests. And today we are back with our live Q&A with a limb lengthening surgeon, one of the best in the world. We got Dr. Craig Robbins from the Paley Institute. Welcome back, Dr. Robbins.
Hey there. Thank you for having me. Sorry we're late. I got caught up on my run and raced home to get here.
Yeah, that's fine. I mean, any type of cardio is fair game when you're looking as lean as you are. I mean, look at you.
Oh, yeah. God, no. I'm still trying to keep up with Holly. You know how it is.
Yeah, she's a beast. Did she do the marathon? You said she was going to do a marathon, right? Or something?
No. She's not a cardio person. She's a eat donuts and bacon and stay fit because she's a PT and works so hard person. But she just had her shoulder surgery 3 weeks ago, so she's still in a sling and recovering.
Wow, dang. Now she's a PT. Does she do her own rehab, or does she go?
That's a great question. No, what she does her own stuff that she's supposed to, but no, she has a physical therapist to treat her because healthcare professionals make the worst patients. We don't treat ourselves the way we should, so we put the responsibility on other people as we should.
It's like when you broke your wrist. I can just see Dr. Robbins like,
Yeah.
Well, I love your shirt. It looks pretty good on you. The Cyborg brand is live. Oh, yeah. That's right. I actually started my diet 3 weeks ago. 10 pounds.
Wait. Back up. So you're what, 16 months out?
Not 16 months. No, it's 23 weeks. So late June.
Wait.
Yep.
I thought it was October was your show.
Well, that's the big one. The big one is late September.
Okay, so this is a pre. So you get
I gotta do a warm up show. Yeah.
Where is that and when is that?
Harrisburg, and then I'll do one in DC, and then I'll do the big one in Charlotte.
Okay, all right. At some point, you'll have to share those dates. Maybe I'll show the audience.
I might even come down to Florida if I find a show down there and just do it. And I'll say, hey.
Right?
The tone. Come on, let's go.
Okay. Wow. Yeah. All right. If you started tanning today, you still wouldn't be ready.
I wouldn't. I'm a pale ghost, so I don't get that from my Italian heritage, unfortunately.
All right. So you're on your calorie taper. What, your 4,000 calories a day taper? What are you doing?
Yeah. So what I did, I initially started off with 1,000 calorie cut. I started at like 3,500. So I'm about 2,650, about an 850 calorie cut. Changed my macro ratios, added a little bit of cardio, about 20 minutes a day. Training's the same. I'm still pretty strong. The weight plummeted. I mean, I was at 220. I'm ashamed to say that. I ate a lot of pizza, but I'm down to 210 right now. So it's about 10 pounds in 3 weeks.
Yeah. So, and what's your 26 weeks out? So what are you going to get? Like 20? What are you getting down to? 175?
Yeah. How much do you weigh?
More than that. Probably about 175.
What the goal is going to be 4% body fat.
Wow. Do you caliper? Do you do the in-body? Or
I do quick and dirty method, different skin pinch tests.
Yeah.
I use the weight scale daily, but then I only count Sunday's weigh-in because that's every week because, it goes up and down.
But right? I mean, you probably can predict within 2 or 3%, I'm guessing.
100%.
Just the way you look and the way you feel. Yeah.
Yeah.
And go.
Yeah. No, the scale will tell you a body fat percentage, but I always trust the caliper. It's way more accurate.
Yeah. And then you do it based on your water intake and all that stuff. Like same time, same.
Absolutely. So after bathing in the morning, no food in my system.
Yeah.
As dry as possible. And then I only look more blurry as the day goes on. But
175.
That's the goal. Because I was 168 last time in 2018. So I'm trying to increase.
Or how much more muscle mass do you have on?
I would say the legs are about the same. But I'd say the upper body is definitely a little bit denser. I probably added about 4 pounds of lean body mass, but I'm not going to cut as drastically. So I'm going to stay a little fuller this time.
Is that because you're planning your taper for later in the season? You don't want to just kill yourself?
You are just so smart about that. He's intuitive. I'm like, how does he know about natural bodybuilding?
That's cool. That's very cool.
Yeah.
Anyway, all right. What are we talking about today?
No. We'll get into that. It'll be cool. The season we'll be doing these as I get leaner and leaner. My face will get chiseled. So
you're gonna look thin, man.
Alrighty, guys. So we are doing limb lengthening live Q&A. So just to reiterate for you new people watching, the way it works is that we have some submitted questions. Dr. Robbins will go through those first, and then we'll go through the chat. And we actually have 2 patients here on the panel. We have Natalie, which is actually one of the Paley patients, Dr. Robbins' patients, and Satoshi, so they can ask questions as well. Or feel free to join, guys. The link is in the description. So let me go ahead and bring on the submitted question. So first up, we have question number 1. Would you consider using trochanteric nails to potentially lengthen closer to the mechanical axis and reduce the slight valgus sometimes associated with piriformis nails?
Okay, so first of all, you got it wrong. So any nail, whether it's troch or piriformis, still goes down the anatomic axis. The anatomic axis is the line that defines the midpoint of the bone, because a rod goes in the middle part of the bone, however it gets there. So, any lengthening along the anatomic axis will give you the potential for valgus. Doesn't matter whether it's a troch or piriformis. Problem with a lot of troch, I shouldn't say a lot. The problem with troch nails, if they're not done properly, is you can get valgus or varus. Lots of issues related to that. But I don't like troch nails because I think they're more of an insult to the abductor muscles, which attach to the greater troch. You're going right through them. Not a lot of people have a lot of experience using piriformis nails. That's why troch nails were invented, but they were used and trained in trauma. 99.99% of nails that go in are for broken legs, not for stature lengthening. There's very, very few of us who use nails in the grand scheme of things, whether it's reconstructive or not, like what Victor had. So it's a lost art doing a piriformis nail unless you do them a lot, and we do them a lot. And it's not that challenging to do a piriformis start in a thin, intact patient as opposed to a broken 400-pound patient, and that's why troch nails were developed. So your question is a good question. I prefer piriformis nails, and the valgus has nothing to do with troch or piriformis. It's related to the fact that the nail goes in the anatomic axis, and the anatomic axis, as you rightly say, is at an angle to the mechanical axis, and that's what imparts valgus with lengthening. So partly right in your question.
Well, that is awesome. Redirected and corrected. I like it. Okay, so yeah, this next question is kind of number 2 and number 4 kind of the same question. I don't know if you've heard of it, but there's a
I work at the Paley Institute, and I fully am aware that my experience does not mimic that of other people. If there is a supply chain issue, it is not a problem at our practice. I don't have much more to say about that. I can't explain why or what a problem may be if a problem exists. But if you ask me, have I had any fear that I'm running out of nails or I don't have nails, the answer is no.
There we go. That's number 2 and 4 answered for you. Number 3 is saying, how do surgeons maintain patients' normal rotation during
These are such good questions. Right? I love these. These are like really. So, Victor, these questions prove the utility and the educational purpose behind your podcast, because we're not getting the same 6 questions, which are great questions, but people are past the basics. What is limb lengthening? How does it work? What kind of nail do we use? Like these are really good, thoughtful, intelligent questions. I think that's wonderful. It's a testament to your 140 something episodes that people are going through. So how do we do it? So there's a couple ways to do it. There are some places where they'll actually make a small incision, put a pin temporarily above and below where you break, and you look for rotation. Dr. Paley developed a technique that we call maintaining the extension moment. So what does that mean? So the femur has a normal bow like that. Let's say I'm laying down, my head is here, my feet are here, and I'm breaking the femur wherever it is in the middle. So when the nail is getting put in through the piriformis fossa, one assistant is literally elevating the nail straight up, like vertically raising the body, an inch or so off the bed. And the other assistant is holding the foot and literally elevating off the bed. So we have the nail at one end, the foot on the other end, the bone is still intact, and we're elevating off the bed just a little bit. And the femur has this natural bone. So now we break the bone and the femur goes like this. It has just a very slight, and the intact periosteal sleeve and the interdigitation of the osteotomy maintain rotational control. So it is very operator dependent, quite literally the operating surgeon, but also your assistants. And we'll often say that we're only as good as the people who assist us, because assistants can hurt us, whether it's intentionally or inadvertently. So in addition to just paying attention to what's in my field of view, I also have to be aware of what's happening in the room. And not to toot our own horn, but I will, That's why we think and we know our results and our techniques are so good, because we have the same team and everybody knows what they're doing. If you do something once a month and it's different teams rotating in, then one person in the room may not have the experience, whether it's the rep, the assistant, the x-ray tech, whatever it is. But we don't just do one. We do scores and scores of nails, whether it's bilaterals, quadrilaterals, or the most common is a unilateral for a reconstructive like what Victor had. So everybody knows what they're doing, and it doesn't mean I'm still not paying attention, but it means that I have a lot of faith and trust in my team, because we've really cultivated excellent teams in our operating room. So great question. And then with the tibia and fibula, we're not doing an extension moment, but with the two bones, getting a rotational change is much harder to do. It has to be a much more conscious thing. So we do sometimes purposely adjust rotation. And if we want to adjust it a certain amount, then we put pins in. We use a special, it's called an inclinometer. It measures the angles, and we put pins, measure the angle, and then subtract however much we're trying to correct. So there you go. I hope that answered your question.
Yeah, I agree. I think these are fantastic questions. When I got his question, I was like, man, I got to put these in. These are great.
Yeah, I love it.
I know. All right. Okay, so we have a few in the chat. I know, people are still joining, but we also have Natalie on here. So let me just bring on this one from the chat. I think it's a pretty broad question, but he's asking basically for patients who get stature done, hiding the procedure from some people. What kind of stories do patients usually use to cover up this whole thing?
So I have this conversation, I don't know, in my experience, probably 50 to 75% of people are keeping this from public, family, friends, whatever it may be. And I'm asked, and my answer is always the same: I will not be part of your ruse, but you don't need me to be part of your ruse, because I am bound by patient confidentiality. And I'm not talking about what happened to you to anybody unless you gave me permission to. That being said, you, Victor, maybe it's all anonymous, you should have a cover story episode where you interview 10 or 20 people offline, or you just take a little 10-minute blurb. These are the things people use. So we had a really interesting patient, a male patient who came in the last few years with his girlfriend, not his fiance, and they were here for lengthening. And he had, I think he was one of our rare people who had consolidation. Something happened and he needed another surgery. And I always ask, who do you want me to talk to afterwards? Whatever. He's like, my girlfriend's here, but remember, she doesn't know why I'm here. So you can tell her surgery was successful, but don't tell her what you did. And I'm thinking to myself, how does that dynamic work? Every day he's going to PT, he's putting a machine on his leg, she's with him every day. But that was their deal. Whatever their relationship was, I don't know behind closed doors. But anyway, but I think as usual, we take a question and we look for other things behind it. So it's a great question because it should be part of your preparation if you're a potential patient. First of all, does it matter? Well, it probably matters, but you're not doing this for other people. So in reality, who cares what they think? This is your journey and you're doing this for you, not for anybody else. So have confidence in the decision you're making. And if they're naysayers, then what do you need them for? But you also have to understand why they're naysayers, because it's scary and there's misinformation and you're going to maim yourself and you're never going to walk again. So use it as an opportunity to get them on this forum, to learn some information about it. So it forces you to think about it. Gosh, if I'm so worried what Mary or Jane are going to think about this, am I really in the headspace that this is what I should be doing? So to circle around, I don't have a cover story for you. I'm not going to help you with a lie or a ruse, but think about it, and maybe it'll make you have some good conversation with the people you may be afraid to tell, for them trying to talk you out of it. And that'll force you to really introspect and decide if this is right for you, and have an open discussion with the people you care about.
That's fair. Yeah, no, and I know Natalie had a good cover story that she was saying before the show. You want to comment on that one?
Yeah, I think Dr. Robbins is correct. I think that, in my personal experience, I just reached 7 centimeters. So I, when I did tell people, they weren't educated, right? And so when they do get this fear, or they just aren't as researched as you are, or as your family is. So my ruse for people who really, it's none of their business, just people, why am I out for such a long period of time, is I just said, hey, I have scoliosis and I'm straightening my spine. And the reason I use that as my cover-up story is because when you straighten your spine, you can gain height.
Mm-hmm.
And so that is my, again, it's not really anybody's business, but, that's, it does come up. And I say, I'm getting my spine straightened. And when I see people again, I might be a little bit taller and I'll say, yeah, I gained a couple inches because of my spine.
Which is true. If you have a curve and you do scoliosis, it's fine. And you could say anything, and it's just you're answering their question, whether it seems valid or not. It's just going to sort of just, instead of there just being this awkward pause or silence, the void is filled, and you move on to the next topic of conversation, whatever it may be.
Absolutely. Now we got this question that just came in. I think it's great. So Darmid is asking, can you ask Dr. Robbins about rotational issues that aren't seen clinically, but are seen in the imaging? So
sure.
So
rotational issues aren't generally seen on imaging because imaging is two-dimensional. So to see a rotational imaging, you may need three-dimensional imaging, such as a CAT scan. So plain X-ray, you don't often see. You can get some indication of femoral anteversion, or you can see some rotational things. But I treat people who make imaging. I don't treat imaging. So it's a conversation. My father, I've talked about, my father walks like this. He's done it. He's 82 years old and has never bothered him a day in his life. You may walk in the door and walk like this. That's not an indication for me to change the rotation of your legs. Now, if you walk like this and we figure out it's from your femurs and you're having femur lengthening surgery and you want me to, yes, I can change the position of your feet at the same time I'm doing the lengthening. So I may point out, hey, 1 foot goes in, 1 foot goes out. Well, you probably would tell me that too. So we'll figure out which is the normal if we can, and we'll match. But I treat people. I don't treat x-rays. So if rotation doesn't bother you, then I'm not going to purposely change your rotation. If it does bother you, we can talk about it. And as Dr. Paley will say, I'm as good at I'm as good at determining rotation as any CAT scan. I think you've heard me say this. We have a lot of patients who come to the Paley Institute to see, now there's 20 something of us. And their second opinions, third opinions are coming from all over. And invariably at the end of a visit, a patient or a family member will just sort of like take a moment and say, I have to tell you, that was the most thorough examination and explanation I've ever had. And it's not like we're spending hours. I can do my full, our speakers can tell you my rotational profile exam is like 30 seconds. It's not hard, but I've done it a bajillion times. But a lot of people don't get a rotational profile. We do. You have to know it. So I'm good with rotation. And if I think something's out of the norm, that may prompt me to say, hey, have you noticed X, Y, or Z? But I'm not going to show you a problem to say it doesn't bother you and then convince you to fix it because there's nothing to fix. So function, preoperative function is important. And if it's bothering you functionally, you're probably going to bring it up to me before I even notice it.
Now, let's say that the lengthening, that's rotation, but like if you're going to add lengthening into the mix, does that change the fact or change what you might do?
No. Okay, so let's talk about how we do it.
Yes.
So there are some centers that they're gonna put pins in to maintain rotation, just to prove they haven't changed anything. Well, you do the same thing. You put the pins in, but you put them at an angle. There's a 15-degree rotation, so maybe you put them in 15 degrees to each other. You cut the bone like you normally would. You put the rod in like you normally would. The difference is you take the bottom part and you rotate it till the pins are parallel, or to effect the amount you are. Sometimes you put the pins in and they're 22 degrees apart and you're correcting 12 degrees. So you don't correct 22 degrees, you correct 10, whatever the math is.
Right.
So you put pins in and then you can perfectly dial in the correction you want. And with rotational corrections, we say plus or minus 5 degrees. Well, why is it plus or minus 5 degrees? Because when the screws go in the rod, there has to be a little bit of play. If there wasn't a little bit of play, it would be a nail going into the wall. It wouldn't be a peg going into a hole. And so there's a few degrees of play. No one's going to have surgical correction for 6 degrees. It's 20 or 30 degrees. So if it's a 20, 25 degree correction, that's going to put your foot in a vastly different place.
I see. Now, I had a consultation last week with a patient who had an angular deformity like Varus, right? And they were saying their degree of variation was like 7. That changes things, right? Like, would that be means for correction?
Yeah. So the normal perfect alignment, or I shouldn't say perfect alignment, average alignment is 1 or 2 degrees of varus.
Okay.
Like if you measure top of the ball to the bottom of the ankle, it's very slightly towards the inside of the knee. Well, some people are a little varus, some people are a little valgus. I'm bowed. I've never taken a full leg x-ray, but I'm probably 5 degrees bowed. And Dr. Paley would say the same thing. And, you know, we both are very active. We've never had knee pain in our lives. Most varus, just as a big assumption, comes from the tibia, and most patients are having femur lengthening. So if you correct, or if you take on 1 or 2 degrees of valgus during lengthening, then in theory, your varus is getting a little bit better, in theory, or numerically speaking. But if the varus is in your tibias and you have tibia lengthening, we can take that opportunity to correct the alignment. Just as we can cut a bone, correct rotation, put the rod in, we can cut a bone, correct angular deformity, put the nail in, and then lengthen after the deformity is corrected. Or sometimes we do a combo. Your tibias are bowed, you're having femur lengthening, but the bowing doesn't really bother you, you're not so sure. Let's do the femur lengthening. Let's get you through it. Maybe, luckily, happily, it decreases by 1 or 2 degrees. It doesn't bother you. Well, if it does, I know there's a second surgery. I'm taking these rods out at some point a year from now. We could use that as an opportunity to correct the varus if we have to, with a plate or screws or whatever way we decide to do it. So if you say to me, I am bothered by XYZ angular rotational deformity and I want lengthening, sure, we can take care of that. Or we could just do the deformity correction with no lengthening, which is mostly what I do. But yes, we can address all of these things during or separate procedures. That's what we do.
That is so cool. That is so cool because everybody has different structures coming in.
Exactly. Yeah. So. And it's recognizing. So where you get into trouble is if you don't recognize it.
Right.
You have bad X-rays. You don't do a good clinical exam, or the X-rays look completely normal, but you go to examine them and the range of motion is not what you expect. You don't blow it off. You got to figure out why. And
right.
So that's why we do a pre-surgical exam.
You bring up such a good point because, you know, those clinics that I see a lot of complications coming from, and this person lengthened into valgus knock knees, and, you know, this is the reason why, because they don't get really thorough clinical exam. So very cool. All right. Let's see here. We had this question. It's kind of a general question from Machiavelli. He's asking.
Machiavelli's back.
Yeah. That's right. He was here before.
That's right. He's been here before. Yeah.
So how soon can they walk after 5.5 centimeters for femur lengthening?
So all things being equal, 5.5 is 55 millimeters, is 55 days of lengthening. You start a week after surgery. So say 60 something days of lengthening. So that's like, I don't know, 9 weeks. So 9 weeks to get the length, and then 2 to 3 months to heal. You're on a walker that whole time. So 5.5 months, you're on a walker. You have some walking muscles, but they're not really doing a lot. So you're 5.5 months from the day of surgery, and I say, put your walker down. Well, your muscles are still atrophied. Your endurance is down. Your flexibility is down. Your strength is down. Now you're walking. Well, if you walk hours per day, you're going to get your muscles back faster. If you walk not hours per day and you sit and work all day, you're not. So all things being equal, we say it's a year from the day of surgery. Now, you work hard, you do less lengthening, it's faster. And 5.5 is a great question because the difference between walking 5.5 versus 8 is huge for many reasons. 1, you stop lengthening a full month earlier. 2, you're tighter after 8 than after 5 in general. 3, it takes a little longer to heal. So as you add length, in theory, it adds time. But we say, just to make things even, expect a year. And if you're really good at your sport, whatever it is, you got to relearn biomechanics in your new body. All of your peers have continued in their sport while you took a year off to lengthen. So if you're really good at something, expect 2 years.
To get back to where you were. Yeah, I agree. Yeah. Great. That's what it means to get back.
It takes a lot of work, though. It's a lot of work.
The recovery
This is not for the faint at heart. Let's say that again.
Natalie's finding that out right now, but she's doing really well.
Yeah.
All righty. This next question here from Khalid, he's saying, for a guy who's afraid of doing a cosmetic limb lengthening surgery, what do you suggest, Dr. Robbins?
Well, first you have to outline what you're afraid of, then you have to educate yourself, and then you have to be 100% committed. because if you're not, it will be a trudge. And I will tell you a story from today. This morning, we were scheduled to do a stature surgery, and as per usual, we're talking to the patient before surgery, and he voices hesitation, trepidation. He was very apologetic about it. And I'm telling this person, what are you apologizing to me for? Oh, I'm wasting your time. And I said, dude, I'm here for you. If you're nervous about this and you don't want to do this, we're not doing this today. Surgery's canceled. Take time, take a day, take a week, take a month, however long you need, we'll figure it out. And it was surprising because you know how much prep a patient goes into to make this decision, and you know how much communication we have about the whole process. But just something on this day, it didn't feel in the cards for him, and we canceled the surgery, and maybe they'll come back, maybe they won't. But this is a big deal. This is a big deal surgery. It's the surgery, it's the recovery, it's everything. There are definitely people who wake up from surgery like, why the heck did I do this? Because things hurt and they're cranky, and then they get over that. But he was just, something in his head told him now is not the right time to do this, and fine, surgery's canceled. Now, we don't want that to happen because he's not wrong. There's resources and time and things. And the time we had scheduled to do that person's surgery meant we weren't doing somebody else's surgery. And, there's certain problems downstream from that. But the point is, he was nervous about whatever he was nervous about. And I've talked to him a few times today, and I don't know if he's going to proceed or not. Maybe he will, maybe he won't. But it just goes to show you that even though he's listened to the podcast and he's done the research and you met us in person and we talked about all these things, there was something in his head that told him now's not the right time to do this. So good for him for voicing that, good for him for recognizing that and articulating. And I think, again, to give the Paley Institute some kudos, good for us for being receptive and not strong-arming him into, oh, you'll be fine, just go through with it. Because that's not right. This is a big deal. Not like I'm convincing him to fix an aneurysm. This is convincing someone to do elective surgery. That doesn't sit with me very well. So anyway.
I love that story.
I'd like to jump in on that from a actually current patient. I think from the patient perspective, being as educated as possible, watching your videos, Victor, understanding what it's like to wake up from surgery, understanding nerve pain, trusting your surgeon, doing the research. And I think as being as educated as possibly can alleviate a lot of those fears. So I think that's, doing this vlog series with Dr. Robbins, the reason we're doing that is to show people exactly what the process is like to help hopefully alleviate people's fears and also, to show people what it's like. There's really nowhere on YouTube where you can watch a precise 2.0 stature journey. Right. And so I hope, I think just watching these videos really helps.
Yep, absolutely. I agree. And thank you again, anonymous person who is sharing your story.
Absolutely. No. And it's thank you to a lot of patients who contribute as well. I mean, patients like you, Natalie, who share your experiences so other people, patient avatars, can listen to you. So that's huge. All right. So this next question here, we could have looped it in with the other one before about using an external fixator to maintain rotation. Do you use that as well?
No. So that would be very much overkill. You don't need a fixator. Well, we believe you don't need anything, but at the master distractor's back. But at the very least, you can use, we say fixator pins. So we may say fixator assisted. So we put fixator pins temporarily above and below where the bone will be cut. We know what the angle is between these pins. You do your surgery, and then you finish the surgery, and you have the pins where you want them to be, whether they're parallel or they're changed by whatever amount you want them to be changed. So we do fixators to do deformity correction. So let's say for whatever reason you have 15 degrees of rotation, 10 degrees of angulation, and I'm doing a tibial nail. I may put on the fixator, cut the bone, do the correction with the fixator. So not over 2 months gradually. I may literally dial in 10 degrees of rotation and angulation and get the bone straight and maintain it with the fixator and then put the nail in. And that's called fixator assisted nailing. in some sense. And those techniques were developed in the 90s by Dr. Paley. He was the first to publish on fixator-assisted nailing. There's other forms of that. But yeah, we do sometimes use a fixator. So, what I do a lot of, unfortunately, is a patient will have surgery. Maybe it's elsewhere. They come in with some sort of malunion. And I think of a medical student who had surgery internationally and came to us after being in a wheelchair for 9 months, told don't walk. He had delayed healing of his tibias. He had what's called windswept. One was like 10 of Varus, one was 10 of Valgus. So it was like the wind blew the true legs like this. He had a clinus contracture, all this horrible stuff. So on the same day, we put fixators on both sides. We took out the lengthening nails. We corrected them acutely with the fixators and put in trauma nails. And he woke up and I was like, now you can walk. And he's like, wait, what? I was like, I mean, you're not going to be able to. You need rehab, but you're allowed to put full weight on your legs, stimulate healing, get your blood. Anyway, and he healed and everything was great. But so we do fixator-assisted nailing either on the front end or in the reconstructed end on the back.
That is so cool. That is so cool. Like straightening the legs and giving somebody back their, ability to walk. I mean, that's huge. That's powerful.
I agree, especially for elective stature. He should have been walking. Like sleeping on a problem doesn't make it go away.
No way. Darman's actually back. He wanted to kind of follow up with his. He said he had a 3D CAT scan was used for the rotational issues, and they were noted. And while it wasn't apparent during the real life rotational profile assessment, example is a Staley complex.
Yeah, Staley. So Staley is a pediatric orthopedic surgeon. I think he's since passed, but Staley is one of the godfathers of pediatric orthopedics, and he has a couple of great books. But he was someone who really quantified rotational profile of children, and he did longitudinal studies of children saying this is the normal rotational alignment in a 6-month-old, 12-year-old, whatever, and kind of followed the natural unpacking process. So think about a baby. I'm going to use Marshall as an example. So Marshall, my big boy who's in the back, when he curls his 120-pound body onto my chair, he wraps him up in such a way he looks like he's like a little fetus. He spherifies his body to maximize, to minimize the volume. Is a perfect sphere is a minimal volume for a mass. So babies are in the mother like this, all wound up. They're not like this. Hey, look at me. And it takes a while for these things to unfold. So all infants come in kind of internally rotated and the feet are wrapped up like this, and over months and months and months, things naturally unwind. So almost all babies are in towing, and then that unwinds with muscles and stretching and all that. So a rotational exam on a 6-week-old is going to be different than a 6-year-old. Maybe I still, yes, Diarmid, if you have a rotational problem, I probably would get a 3D CT just to quantify the number, especially if it's asymmetric, post-traumatic. Your left is 30, your right is 18. We're going to correct 12 degrees. So yes.
Uh-oh. Am I cutting out?
Do 3D.
Okay. Got it. Very cool. That was a great answer. All righty. Let's see here. Next question we have. Esther is asking, I'm scheduled for femur lengthening in New York. My doctor is saying that PT, physical therapy, is only once a week and the rest can be done at home, plus it's the opposite approach that is done at Paley Institute. What do you think about this? Any downsides?
I cannot speak to their results. I can only speak to ours. So that's a conversation between you and your surgeon. If we thought that was the best way to do it, that's how we would do it. That's not how we do it. Problems can occur slowly but rapidly. And if you have therapy 5 days a week, that's 5 opportunities to catch a problem, as opposed to once a week, you lost 6 days. So that's all I really have to say about that.
Yeah, there you go. Very fair.
I can jump in on that. I don't think I would be able to get the efficacy of the stretches that the PT people give me at the Paley Institute on my own. So, yes, I have an hour once a day, sometimes 2, especially now that I'm at 7. However, I don't think that the stretching is the same. I just don't think it's possible to get the same efficacy as a trained PT person. And it is true that doing it once a day at the Institute is extremely, extremely helpful.
And hard to quantify. I've seen plenty of people from outside who have had 6-7 centimeters in their tibias, and 2 years later they finally stretched out. That's not how we do it. I don't want you walking on your tiptoes for 2 years, and I'm not going to do soft tissue releases. I'm going to keep you from getting the contraction. But nonetheless, the human body is remarkable, and given enough time and resources, it probably is possible to recover from a lot of misadventures, let's say. But we think we do a pretty good job of this. We've done a lot of this, and the more therapy, the better. So maybe you can get away with it. Maybe your results are going to be fine a year and a half later. We like to think that having therapy by a qualified therapist 5 days a week is better than one. That's what we think, and that's what we do.
Yeah, and I actually wanted to ask you about that. So, isn't it also important that the therapist knows where to kind of position their hands and stuff? Like for femur lengthening, you don't want to just stretch the leg because emptying get damaged.
So the way, and this we can expand the conversation with, what can I do before surgery? Yeah, you could join Stretch Lab, or you could do yoga, you could do whatever. There's nothing you can do that's going to make surgery easier, better for me. You doing prehab or pre-stretching is going to make you used to being stretched, so that's less discomfort for you. Surgery hurts, stretching is uncomfortable, put them both together, and that doesn't help you much. So if you're used to being stretched and sore, that's great. But it's not going to make your surgery any easier for me. You're not magically going to not need a soft tissue release of your iliotibial bands because you stretch for 6 months. It doesn't work that way. The point is, and I forgot what my point is, that when you're doing your stretching before surgery, you're not at risk for anything. But exactly what you said, now you have a nail in that has a certain weight bearing restriction. When you're stretching, you're putting torque and bending, which is where the nail is the weakest, as opposed to axially loading. So you are absolutely right. Just grabbing the ankle and cranking it, you can cause harm. Mm-hmm. So all PT is not created equal. So I'm sure their one PT a week is a very skilled limb lengthening therapist, but you can't just come to Paley for a week and go to Oshkosh and get a PT to crank on your leg because they can break you and do harm. And so as part of my discussion, when patients are finishing and graduating and getting ready to go home, keep doing the stretches as you're instructed because that is protective of the nail. But I will tell you, when your bone is healed enough, that now we don't have to be safe about torquing and breaking. The bone is great. Your muscles still may be tight. Now you can go do whatever the heck you want without fear of causing it. So that's a great observation and a great question, Victor. Yes, you are at risk for harm with an unskilled practitioner. Inadvertently, they're not doing it to be mean. They just don't know. Right. And so, yes, you need a skilled limb lengthening internal fixator therapist to know what they're doing and help you.
Yep. Great questions. That's huge. Yeah, because I think that's often overlooked in this. People say, oh, well, I can do the surgery with a good surgeon, but then PT I can do myself. And I don't think that's quite the case, especially when PT makes up a tremendous amount of this process. So yeah,
I think, if you press me to task and say 4 centimeter lengthening PT once a week, you're going to be fine.
Right.
But you can get into trouble with 4 centimeters. Let's be clear. But 4 is not 5, is not 6, is not 7. I think our anonymous guest can confirm it is a hell of a lot harder. Not just because it actually is, but it's a marathon, man, and your resources are depleted emotionally, and you're exhausted, and you want to go home, and you just want to be done with this. And it's your last 4 pounds on your taper, Victor. Those are the hardest, right? You can lose 10 pounds in a week. Give me a break. You do that without even thinking about it. And so those last centimeters, you really need somebody to really help you cross the finish line successfully.
Absolutely. I think the other great thing about the PT at Paley is the community there. I go in every day, and there's other people doing elective stature lengthening. The PTs themselves are so knowledgeable. They've seen it all, right? They've seen it all. And they are just a wealth of information. And it's really great to go to PT and have a support group of other people doing the exact same thing that you're doing. You might be able to give advice to someone else because you're further along, or someone else is further along and they're giving you advice. And sometimes I go to PT for like 3 hours just to talk to people.
Thank you for saying that, because I think it's great. So benefit, people say, where should I stay? I say, if you can, stay at the host hotels, because the worst case scenario, you're going to meet other people who are going through what you're going through, and you are now going to have a peer group. The people who come with their family, rent an Airbnb, and are very isolated, I don't think have quite the same experience, because their families there are very helpful, but they're not going through it. But exactly what you said, you're a PT and you see your same 6 people on the bus, and you're all going through it together. And I think that's really a huge thing.
Absolutely. Absolutely.
One more thing. So we had a patient, it was a child who had reconstructive procedure, and between one day and the next, an area of concern on the leg popped up. There was swelling that was not there the day before. Like unequivocally it is there and it wasn't. It went from a phone call and an email to seeing me in person in less than 2 hours. And that person actually had a surgical procedure to drain an abscess 12 hours later. Now, imagine if it was waiting 5 days and then, oh, let me reach out to the doctor. I don't have that much of a relationship. An email is sent. It's 6 days later. But exactly what you said, anonymous person, we're all in communication. We're all on the same team. And we've seen all the things that could go wrong. So they're recognized early, communication across the team. Kudos to the admins and the people behind the scene that made all these things happen. But that's what you get at the Paley Institute. It is an institute designed for limb reconstruction, parentheses, stature lengthening too. You get all of that. It's yay, it's Candyland for us. You tell I'm excited about it.
Right. No, absolutely. Because I again, one big problem I hear about other clinics internationally and like where a lot of complications come from is sometimes you won't see the surgeon for 3 weeks. I mean, that's a problem. That's scary. I'd feel scared. Like I wouldn't want to wait. So
I told you the story of the guy who comes on who called me from the hospital bed in whatever institute. There's a problem, and the picture is a hole of the tibial osteotomy, and you can see the nail through the skin. And the whoever non-surgeon is like, pack it with betadine, you'll be fine. I'm like, dude, leave that hospital. And 2 days later, he flew around the world and came in and we took care of him. Yeah, that's scary.
It's so scary. It is. It really is.
And let me take a second. It doesn't mean bad things can't happen anywhere, including with us. It doesn't mean complications can't happen. Nothing is complication-free. But it's recognizing, it's knowing what things can happen. And when you know what can happen, you know what to look for. And when you know what to look for, you catch things early. And if you catch things early, maybe you minimize the downstream consequences. Mm-hmm. So not to say we're so perfect and we don't have problems. That's not what I'm saying. We have experience. With experience comes knowledge. And with knowledge, you learn how to treat things. So that's what you get with us. You get that experience, the knowledge, and we're all on team you, whoever you are.
Right. I mean, that's and things like that. That's what affects the stigma of this procedure when, people say, oh, you get butchered like Frankenstein, but when you experience surgeons, it doesn't turn out that way. You turn out really well. So
yes.
Exactly. Fingers crossed. All right, so Nicholas has a good question. He says, would my recovery be shorter if I had a very, very strong glutes and hip flexors and an only lengthening 1 inch on my tibia, 1 inch on my femur? Could I do it in about 3 to 6 months?
So lots of things to unpack here. So the strength of your glutes and hip flexors is going to plummet after your surgery just because of surgery. But if you're strong before, you'll get your strength back. If you're doing 5 centimeters total, I would beg you to do it in your femurs. What are you doing? No one's getting it. And I let's be very clear. I'm not, Nicholas, I'm not trying to belittle you or I know nothing about you. I don't know who you are. All things being equal, assuming you have normal body proportions and all these things, 1 inch above and 1 inch below is twice the risk. It's 6 bones instead of 2. So I guess it's a little more than twice the risk. But why? What are you trying to accomplish? You're never going to notice. I would strongly encourage you to do it all on the femur. And let's say I'm wrong. And you're starting to lengthen femurs only. And you get to 1 inch and you're like, oh, I don't like the way this looks. Fine, stop. Do your 1 inch. A couple months later, when you recover, then go do your tibias. But having done this a lot, I think you could do 2 inches in your femurs, 5 centimeters, never need surgery on your tibias, and be so darn happy. And if you did that, it would be 2 months of lengthening, probably 2 months of healing. Still need a couple months to recover. So I don't think, definitely not 3 months, even if you just do 1 and 1, not 3 months, maybe 4. So 7, 8 months, 2 inches, all in the femurs, less risk, 1 surgery, more reproducible. That's what I would recommend.
Yeah. I think also you mentioned before that the femur is just it heals, the bone heals better than the tibia.
It heals faster, you lengthen faster, it's easier to rehab because of lever arms, more reproducible. Yeah, right. and that's no coincidence. That's why we do femur more than anything. Sometimes I feel like we're like those call-in legal shows or Judge Judy, where you're condensing down a very complex issue into 4 talking points and move on to the next one. And I think we both know we've done this enough together, Victor, that we're very good at at seeing what the other person is thinking, and we can guide a conversation to make points, because we know in the next conversation we go to other points. And I think we're very good at that. So Nicholas, thank you for the question. There was a lot of good stuff there to unpack.
Absolutely. I think one day, I think that this surgery, like, it'll get to the point where everybody kind of understands, or hopefully will become well-versed enough that you can kind of pack it into a question like that. And it's like, oh yeah, you get 5 centimeters, blah, blah, blah. So,
yeah.
All right. Harith is saying, do you think you are young enough, if you're 20 to 25 and you can get away with telling people you just
have confidence in what you say and sell it? Yeah, sure. Why not? 25 probably not, but 20, sure. Yeah, I hit a late growth spurt. Why not? What, they're going to question you? Come on. Yes. And we've talked about this, a strategy some people do. And I had this conversation with someone by consult today. She's a 40-something-year-old woman who lives wherever, and she's thinking about doing this. And she wears heels. She's like, I wear heels. And I say, what you may want to do is stop wearing your heels before you come down here. Because then when you go back, you'll only be marginally taller than you were. And then a few months later, when you've recovered, then go into your heels. And that's a way to, trick isn't the right word, but you know what I'm saying. So a lot of our guy patients who don't wear heels, they'll wear lifts. So for a while before surgery, they're wearing lifts in their shoes, give them 3 centimeters, 4 centimeters. Then they have their surgery, they go back, they don't wear the shoe lifts, so they're only marginally taller. And then maybe they go back into their shoe lifts, and that's a way to sort of gradually increase. But at the end of the day, man, people are so wrapped up in their own stuff, they're not going to notice. They're not going to they'll notice you're on a walker and wonder why, and then you tell them your story and the conversation's over. But they're not going to be like, wow, did you notice Bob looks 2.5 inches tall? They're just not. We're all wrapped up in our own. We got our own things to worry about. That being said, once somebody notices, you're going to be all the topic of conversation. So you're not wrong, because everybody likes to gossip. And if you read the book Sapiens, I don't know if you get off topic, but in the book Sapiens, there's a whole conversation that the cognitive, our brains developed to gossip, because gossip tells the cave people where the tigers are that are hiding to eat you. Gossip tells the neighbors next to you where the bad water is. You talk about yourself and other things, and you save lives. So, our ancestors, our brains developed because of gossip. And here we are doing the same thing, millennia later. But anyway.
That is so cool. I love that little tangent. Yeah. I really didn't know that about gossip. That's crazy.
Yeah, it's
called Sapiens. Huh?
Obviously, gossip is communication, and it's depersonalizing and bringing a third person instead of just yours. There's a lot built into that. I'm very oversimplifying, but Sapiens is a really good book. It talks about.
I'm gonna have to listen to that. I actually found out there was a patient that actually used their cover story. They told it to their network of friends or whatever, and they just said, "Oh, that's crazy," and then they just blew it off. They didn't even care. Like they just want to hear something. So have a cover story. Say it. That's it.
Sell it. Just sell it. Yeah, this is what I did. Okay, fine. So I had a guy today. I saw one of my older patients who came in for follow-up. X-rays are great, whatever. And I said, so what do you think? And he's like, dude, my brother didn't even notice. I'm 60-something years old. I've known my brother for 6 decades, and he didn't even notice. Like, yeah, see, exactly. But you didn't do it for your brother. He did it for you, and he's happy he did it. So there you go.
Absolutely. He'll notice the change. That's what matters.
Yeah.
Yeah. Oh my God.
Didn't even notice.
All right, let's see here. Let's get so the editor saying thank you for your response. Thank you. Here it goes. This question about the knee, Leonardo, would this surgery have any negative effect on the knee, perhaps slight misalignment or patellar stability?
That's Leonardo, that is a wonderful question. So I can answer your question by telling you anecdotal and personal history. So yes, technically every femur lengthening has the ability to impart some valgus, and yes, if there's some valgus, that can throw off knee mechanics. So back up and say in the thousands of patients who have had limb lengthening with an internal nail, and I'm not just talking stature, any internal lengthening nail will lengthen across the anatomic axis and has the potential to cause valgus. How many people have had to have knee reconstruction, patellar realignment? I'm sure it's happened, but I can't think of one. Honest to God, I can't. So yes, potentially it could, but let's say it does. Let's say you lengthen so much or whatever, and it just happens that now you have bothersome valgus. Well, valgus is a known, and it's not a complication because it's predictable. Valgus alignment or relative valgus or increased valgus, however you want to couch this, is a known potential problem. And if that happens, and it's bothersome to you, it can be fixed. Now, why am I going to have one surgery to have another surgery? Well, that's part of your discussion with yourself. there's a remote chance that something might happen. Is it worth being taller? That's part of the equation. Blood clots, fat embolism syndrome, malunion, non-union, contraction, nerve issues, all these things. Add one more, potential rotational malalignment. Somebody sneezes in surgery, the leg moves 4 degrees. Is it really that, or your muscles are tight, or you get some hip tightness that you don't stretch out and you walk with your foot rotated? Anything can happen. So will it be recognized and can it be treated? So for whatever reason, if there is a less than optimal outcome, be in a surgical center where that less than optimal outcome has an answer, whether it's surgical or not. So yes, should you develop knee problems after lengthening due to misalignment, malalignment, whatever you want to call it, it can be corrected. It may be surgery and recovery and all those things, but yes, it can. That being said, I can't think of one who has complaints or patellar instability or whatever it may be.
Yeah, but I think that goes to your discussion before about like having a surgeon who can recognize that and prevent it in the first place, right? Like,
yeah, well, you can't prevent the valgus. The valgus is part of the lengthening across the anatomic axis. Mm-hmm. Is it clinically bothersome or noticeable?
Okay.
That's the thing. And again, and our anonymous callers can probably attest to, I try to counsel every patient on every visit. Yes, you're getting taller, measure on the wall, but look in the mirror.
Yeah.
It may look worse because your legs are skinnier and your knees are more knobby and you lost 10 pounds or whatever. But look in the mirror, sit in a chair and look at the ratios of your knee height relative to your hip height, because you may find that the aesthetics are changing. And that last 2 centimeters of height, you put it on the scale. What's more important, the more height, or are you starting to notice the aesthetics? I'm not going to tell you your legs look X, Y, or Z. That's for you to decide. You're getting your hair done, you pick the color. I am just a hairstylist, right? I'm the surgeon. I'm going to help you do whatever you want, your color, your length, whatever it is, and I'm going to help you do it safely. But I'm going to remind you, look in the mirror. I don't want you to have remorse that you don't like the way it looks, and you may have to make that decision in your brain. Sacrifice that last bit of height to keep your legs and the aesthetic you want. Mm-hmm. And that may apply to the valgus or varus or whatever malalignment there may be.
Now, this question from Prosper, he's saying, can this valgus or misalignment from the femurs?
Well, depends where the problem is. If the problem's in the femurs, you're not going to create a problem to fix a problem. So if you get valgus in the femurs, you would correct it in the femurs.
Okay.
So
that answered.
Yeah. But it's recognizing where the problem is, which is what we do.
Mm-hmm. Yep. Okay.
So,
all right.
These are the best questions we've had, I think.
I gotta say,
they're sophisticated. They're like second and third order questions. It's not what is limb lengthening, what is the weight bearing of a nail. It's like these are really good, thought provoking. Mm-hmm. Like this is awesome.
It's like like limb lengthening 3.0.
Yeah, truly. Oh, and a total sidebar.
Yeah.
So I listened to today. I did my run, and I'm listening to a podcast called "Stuff You Should Know." I don't know. Mm-hmm. It's a bunch of dudes who talk about random things. I don't know when this episode was filmed, but they have 500 million downloads on iTunes.
What?
Oh my gosh! Yeah, more than anybody. It's this great podcast. I freaking love. I shouldn't say that. I love it.
What do they talk about? Like
everything. So I've heard them talk about dandelions. Today they were talking about the pill. They talked about Tetris. They talked about weeds in your yard. They talked about everything. Like it's just cool stuff. And they have such good banter. And they're self-proclaimed nerdy dudes who just talk about like it's really they research something and they talk about it and they go back and forth. It's really a great it's a great repartee they have, kind of like us. So that got me thinking. I'm like, stuff you should know. You can have limb lengthening surgery. So Victor, I charge you with tracking these people down and getting us on that and Joe Rogan.
That's what I want to do. Is I think you
get us on Huberman or get us like
on a big platform. I was thinking about that on my cardio. I was like, how can I get on Joe Rogan or something like that? So
yeah. So anyway,
absolutely.
Now, ignore if inappropriate. As a runner, master distractor. Like I run. I'm not a runner. There is a very big difference. And when I run, everything hurts because my cardiovascular. But I just had pain on the ball of my foot, and I took off until the pain went away. And it hurt me that it hurt. Like for 3 weeks, I was walking on the side of my foot. I ignored seeing my foot and ankle partner who saw me limping. He's like, "Are you limping?" "No, I'm not limping. Leave me alone." "Put a carbon fiber shank in your shoe." "Oh my God, I did, and it got a little better." But anyway, there's a bajillion things that can hurt you. So stretching and all that stuff. Go to running.com and self-diagnose. But whenever someone is a runner or running and they have pain, the first thing I ask is, have you changed your shoes? What I would do is go to the last pair of shoes you did not have pain. And if you don't have pain, use those shoes. I discovered 30 years ago, Nike make my knee hurt on the inside. I don't want to say brands. One brand I get inside pain, one brand I get outside pain, two brands I get no pain. Those are the two brands I use. And they're all made in China, anywhere, and whatever price markup. But really, go back to your last shoes that didn't hurt you, and it may be as simple as your shoe wear. But it is off topic. I wish I had more to say on that.
No, that's huge. I mean, it goes to a lot of these patients just want to get back to normal life and get back to running. So I think that's a well thought out topic. Okay, so we answered his question. Oh yeah, we answered that. Okay, so here we go from Dylan. Hi, I'm 20. I'm 5'9", just 5'10" in the morning. I want to get 3 inches of the femur. Am I ungrateful or should I do it? Great channel. Thanks.
People are going to say what they're going to say, but it doesn't matter. My opinion doesn't matter. If it bothers you, and how do I define that? I don't know. Does it bother you enough to have your legs broken, relocate, be on a walker for 6 months, walk awkwardly for 3 more months, have the potential low, but potential for complications and problems and unplanned surgeries and all these things to be taller? I don't know. Walk around with shoe lifts for a couple of months and see if you notice a difference. And then, if you want to get rid of the shoe lifts, have lengthening. You should be grateful. Don't be ungrateful for something you don't have. Be grateful for what you do have. You are a healthy person with the means to be online, even entertaining the thought of doing this, which must mean you have some support, some finances, you have a place to sleep, you have food to eat. Doesn't mean you shouldn't splurge on yourself, because that's what you work so hard for. So don't be ungrateful, but just don't do it unless it's really bothering you. And do it for you. Don't do it for anybody else, because at the end of the day, it's your body and it's you. You have to be happy with you, whether it's your 5'9" PM body or your 5'10" morning body.
That's well said. So we have 2 more questions, and then we'll probably ask Dr. We'll do our outro. But Dr. Robbins is always asking what he's cooking and what he's reading. So this question here from Ginger Cat, it basically says, quick question. I had the precise nail, and I just finished lengthening my final session on the femur, and I was doing it, and I heard it pop. How common is that?
So first of all, it depends where the pop is from, but I'm going to turn this into the question I think you're asking. If I take a precise nail out of the package right now and I lengthen it all the way to the very end, just sitting on the table, and then I put the ERC on it, and it's now up to 80. It can't go any more than that, even if I want to. And I put the ERC machine on. That rod has a clutch built in that won't let it go more, but it won't break the rod. So when that happens, either you consolidate or you reach the end of your lengthening, one of a few things can happen. You'll hear a change in the sound of the lengthening. There will be a shimmy in the machine that wasn't there, or there may be a clicking or popping. So if you finished and you hit 80, then probably that's what it is. So how would you know? Do another lengthening session. If it happens 2 more times in a row, then you've either consolidated or you're out there. And I shouldn't say that. It's not that you've consolidated, is that there's tension in the system, either at the end of the nail, or I have patients who get weird noises or shimmies and they are lengthening. But if you do 5 millimeters of lengthening, your x-ray may only show you got 4 millimeters, because the bone is so dense, it's resisting lengthening. So what do? We increase the rate. We do all these things. We make sure you're lengthening, symmetrically in between visits. But if you've reached the end, very likely you've reached the end. Congratulations. Good for you. Rehab hard. Don't break the nails.
That's awesome. Wow. So that's what you're looking forward to, Natalie, there. All right. So last question here is from Prosper. Again, he's saying, with that mentioned before, if complications do arise from the lengthening, whatever it is, and I need emergency and corrective surgery, do doctors usually help discount the extra cost of corrective procedures?
So the funniest thing ever, hold on one sec.
I hear Marshall. We got Casey over here. Casey's my big puppy. Don't look at me like that. You want to get up here and say hi to everybody? Come here.
You guys see this? Prosper. Look at his icon. Look at his avatar.
Is that a...
It's hot.
Oh, it's the same stuff. What is that, seasoning?
This is the extra hot. Holy crap, is this hot.
Oh,
I was so hot. I put on my broccoli last night.
Man.
Yeah, so Prosper, that's a really good question. So if it's emergency, we say, and the Paley stuff will say, have about 10%. I don't know if it says 10% or $30,000, whatever the amount is, on hold just to cover any emergencies out of my life. If you fall down in the shower and break your leg, or God forbid you get an abscess, or who knows what happens and you need surgery, there are costs associated with that. The anesthesiologist doesn't care what happened. The radiologist doesn't care. I mean, we care, but you know what I'm saying. There are costs, whether it was somebody's fault or not. There's a surgeon in the room for 3 hours, and there's a cost for implant. So it's not free. The rare time where a nail stopped functioning, there's not a charge to replace a broken nail. There may be charges for the equipment and time. Often, in talking about finances gets a little tricky, but some things might be covered by by insurance. You trip and fall and you break your leg. That's an emergency. That's not a consequence of the lengthening. So sometimes it's covered by you. Sometimes it's covered by insurance. But in general, insurance companies will look for any reason, and if they know you're having elective cosmetic surgery, they're going to say the onus is on you. Mm-hmm. Another reason, perhaps, why you go to a place that we think minimizes complications relative to others, and you recognize and stop a problem. And that's why I see everything comes back. My job is to protect you from yourself and what you don't know, and keep you from getting to a point where you can't recover. Mm-hmm. So there you go.
Yeah, absolutely.
But everything is open for conversation. Who's paying, what's the cost, and everything should be above board and clearly discussed before you have your surgery. There shouldn't be any surprises.
Great. Save money in the long run that way.
Yeah.
Maxime, last question. I know this just popped in. I think it was, we missed it earlier. It says, hi, is recovery faster and simpler for short lengths, such as around 3 centimeters?
Yeah.
Yeah.
It's 512 Austin. Go Austin, my alma mater. Or maybe it's May 12th birthday. Who knows what? Yeah. In general, shorter length is faster healing, but there was a certain minimum healing time. If you lengthen an inch, it may not take 5 months to heal, but it may still take 2 or 3 months to heal. But it, in theory, is faster than 6 centimeters.
Mm-hmm. Right. All righty. I think that's all the questions we have. So, Dr. Robbins, we're going to ask you, what do you? Well, you have that slap your mama.
Yeah, that's right. So in the background, if you can hear, there's rumbling tummies. I completely forgot today was Tuesday, so I have teriyaki skirt steak and filet in the sous vide ready to go on the grill. The moment I hang up, I got 4 hungry people in the kitchen eating all the pre-stuff, eating the broccoli. Yeah, I know, we're coming here.
Come here.
Right. So my daughter graduated college and she is back home and she's doing hard 75. Do you know what that is?
No.
So she can explain it better, but it's this total body mind thing. You commit to 75 days of all of these things. No alcohol, eating good, 2 workouts a day, 45 minutes, at least one is outside. You got to read an actual book a certain amount a day. You do all these things, 75 days. If you miss one, if you read 9 pages instead of 10, you fail, start over. So anyway, so she's doing all this great stuff. So we went to the market on Sunday and got all the stuff. We're about to juice tonight and all that. So we have all the healthy stuff ready to go. I just have to stop talking. So that's what's on the agenda for tonight. Is
skirt steak. I want that. Are you using the slap your mama on it?
No. So the slap your mama will go on the veggies. No, the skirt steak I put in the sous vide for 2.5 hours in a teriyaki glaze. Oh. And I'm just gonna go hit it on the grill to char it. It's gonna be so good.
We're not gonna hold you up too long because that sounds good and what's on too. Yeah. But what are you reading, Dr. Robbins?
Reading. Okay, so I've read so many books this month. I have to look them up. So I read like a good for my brain book, and then I read fun books. So there is a series called The Wayfarers by a woman named Becky Chambers. It's sci-fi, so it's a 4-book series on sci-fi. She's created this whole alternate universe with different species and interactions and communities, and just kind of fun stories taking place in that universe. But a great book I read apropos to January 6th, which just passed, is called Courage Under Fire. And it's written by the retired chief of the Capitol Police, who was in charge of the Capitol the day of January 6th. Mm-hmm. And whatever your political stance may be, whatever you think about pardoning the people or not, It is a very good read. His name is Stephen Sund, S-U-N-D, Courage Under Fire. But he takes you through the behind the scenes political stuff that you're not aware of. Like, I didn't know that in the Capitol building, one half of the protection is under the Congress and one is under the Senate. And if there's an emergency, you have to have in writing permission to do whatever you have to do from both people. Well, an emergency was happening.
Yeah.
And the Capitol Police needed permission from both people to get resources. Well, there was an emergency and they were sequestered, and it took hours to the behind the scenes nonsense that was happening because of his hands were tied. The information was there was bad intel that was withheld. There was stuff in the chat rooms for weeks. We're coming with guns, and that was never passed on to Capitol Police. Like, really horrible. So that's really interesting. One of my PAs told me about a book called All the Light We Cannot See by Anthony Dewar. And I had no idea what it was about, but it takes place, it's from the point of view of a woman and her father in World War II who are holed up in France during the occupation and the bombing. Mm-hmm. And it's just her personal story and their story of being civilians caught in a war-torn country that is first resisting and then occupied, and then the war is coming to an end. And you think the soldiers get food, the soldiers get a place to sleep, the soldiers get whatever they want, but it's at the expense of the civilian population. Just really saying war is hell and it's terrible, but interesting. And then the last one was Rick Rubin, The Creative Act. So he's an artist, kind of talking about, if you're an artist, how do you tap into your artistry and what can you do to get your inner muse and express whatever it is that you have inside. So those are like 5 or 6 of the books I've read. I'm sure there's more, but that's just, Fear and Loathing in Las Vegas, Hunter Thompson, Buddhism for Dummies, You Can't Hurt Me by David Goggins, Outliers by Malcolm Gladwell, On the Road with Jack Carroll. Yeah, I guess I've done like 10 books. Yeah.
How does he do it? This is crazy.
Triple speed when I'm running, man. That's it.
I know, but that's amazing that you went through all those. I think I may have gone through one book in the last time. You did like 18. Yeah. That's crazy. Well, that is amazing. Well, thank you again, Dr. Robbins, for coming on and answering everybody's questions. Thank you, patients, for asking those amazing questions.
Great episode.
Great question. I know. We got to give.
They all feed on each other. You couldn't get here without the other ones. So
exactly right. So they must be paying attention and watching the series. So thanks to all the guests on the panel, Natalie.
Yes.
And so we will be back next week, and we'll have Dr. Robbins back next month. Enjoy that strict steak. We'll see you guys next week.
I love it. All right. Peace.
All right.
Bye.
See you guys. Bye.